Hello everyone, this is Dr. Rajesh MISHRA and you are watching Health Super Specialist. So, the management of community acquired pneumonia. The last video we had discussed the initial management. Now, why should you listen to me? Just because I am saying Health Super Specialist saying should you follow that guidelines in your clinical practice? No, I don't believe in expert opinion. I believe in society guidelines. As in all my previous videos I've stated, doesn't matter what I say, what matters is what evidence says. This is the age of evidence-based medicine. What we do has to be with a background of good amount of evidence. So this video we discuss the management of community acquired pneumonia as per the American Thoracic Society guidelines that came in 2019. So as per the criteria we have discussed in our prior videos regarding how to categorize the pneumonia. Again, we'll use the same American Thoracic Society criteria for severe community acquired pneumonia, in which there are two major criteria and 9 minor criteria. Two major criteria are like the patient who require mechanical ventilation for respiratory failure and the patient who are in requirement of vasopressors for septic shock. The minor criteria: respiratory rate more than 30, PF ratio less than 250, multilobar infiltrates, confusion, blood urea nitrogen more than 20 milligrams per dl, hypothermia, leukopenia, thrombocytopenia. So, out of which, if 1 major and 3 minor are present, the patient is classified as a severe community acquired pneumonia. Fine. Now, for the management of patients with community acquired pneumonia, we need to categorize them in separate boxes. So, first, a patient who is healthy and hearty without any comorbidities. By comorbidities, I mean to say no diabetes, no hypertension, no chronic kidney disease, not on any immunosuppressants, nothing. What do? Give something like amoxicillin, or maybe an azithromycin, or maybe a doxycycline. Done and dusted. Finish. Okay? A patient, outpatient, coming with comorbidities, diabetic, hypertension, CKD, elderly, smoker, alcoholic, with these comorbidities. What do I give? Either I give something like amoxicillin clavulanic acid, or maybe any cephalosporin such as cefpodoxime proxetil with clavulanic acid, along with a macrolide, azithromycin 500 OD 5 days, clarithromycin 500 BD 5 days. Ample, sufficient. Or there is evidence which states that monotherapy with fluoroquinolones are as good as this dual combination therapy. I don't know how practical it is to implicate in our population of Indian population with so much of resistance with levofloxacin which has been used since ages, but yes, the evidence states that. Also, what you can do is you can use something like a amoxicillin clavulanic acid or a cefpodoxime proxetil with clavulanic acid plus a fluoroquinolones. That's what the guideline says. Fine. A patient now, inpatient. Patient is admitted to hospital and he is not at risk of MRSA or Pseudomonas. The risk factors for MRSA, as I told you, antibiotic in the last 90 days. Any patient who has taken antibiotics in the last 3 months can be considered at risk of MRSA. Any patient who is hospitalized for more than 48 hours in the last 3 months, at risk of MRSA. Any patient who is being immunosuppressed, at risk of MRSA. Any patient who has chronic kidney disease or maintenance hemodialysis, at risk of MRSA. Fine. Pseudomonas, at risk of Pseudomonas. Which are the patients? Age more than 65 years, at risk of Pseudomonas. All the patients who are immunosuppressed on corticosteroids, they are at risk for Pseudomonal infection. Patient on CKD, maintenance hemodialysis, malnourished patients are at risk of Pseudomonal infection. The patients who are in and out of hospital, more than 48 hours of admission in a hospital in the last 3 months, are at risk of Pseudomonal infection. So with all the risk factors, if someone is there, inpatient, same. What you have to do is, if the patient is not at risk of MRS or Pseudomonas, the factors which I have been describing again and again, in this video also I have discussed, then not at risk of MRS or Pseudomonas, will give an cephalosporin like ceftriaxone, non-Pseudomonas cephalosporins, remember, ceftriaxone, cefoxitin, cefotitan, plus a macrolide or a fluoroquinolone. That means you add a ceftriaxone plus give azithromycin or clarithromycin, claribint, or what you can do is you can add some levofloxacin in place of macrolides, in place of azithromycin. So that will treat up your patients who are not at risk of MRSA, who are not at risk of Pseudomonas. Any patient, if found to be at risk of methicillin resistant Staph aureus, MRSA, will give MRSA coverage. How? Simple. Vancomycin, 15 milligram per kg, comes around 1 gram. We'll use vancomycin, 900 milligram to 1 gram, or Linit, injection Linit, 600 milligrams BD. You can use the tablet formulation also. So this is for methicillin resistant Staph aureus coverage. Okay. If the patient is at risk of Pseudomonas, what do? We'll follow the same principle, but this time with antibiotics which cover Pseudomonas. So we'll use the same beta-lactams which cover Pseudomonas. Now, initially what we used, ceftriaxone. This time what we'll use for Pseudomonas, cefepime. We can use ceftazidime. We can use piperacillin tazobactam. They are all cover Pseudomonas, best cover. Piperacillin tazobactam, ceftazidime, cefepime, or imipenem, meropenem. These all are good, very good anti-pseudomonal coverage. So any one of this along with some macrolide or a fluoroquinolone. Fine. Severe cap at risk of Pseudomonas. This is the management that we used to follow. Okay. Now, supposedly a patient is in hospital. Should all patients undergo test for procalcitonin? Recommendation says no. To initiate the antibiotics, you don't need a procalcitonin. Yes, to hold the antibiotics after completion of 5 to 7 days of antibiotic course, you definitely need support of a procalcitonin to hold the antibiotics. Fine. So this is the thing about procalcitonin. Should all patients undergo blood culture? For mild to, for non-severe cap, no. For severe cap, yes. For severe cap, you have to take the blood culture. Regarding the guidelines for BAL, mini BAL is as good as BAL, so no BAL as such. Should steroids be used for community acquired pneumonia? Guidelines recommends no, unless until there is refractory shock, no use of steroids in community acquired pneumonia. So these are the some of the important management guidelines for community acquired pneumonia. This is how we manage a community acquired pneumonia in an hospital setting, in an OPD setting, or in ICU setting. So I'll come up with more interesting videos. Till then, thank you. Thank you very much.